And today we are indeed lucky and are honored to have amidst us Dr. Burton Kushner, a prolific, brilliant, and a genius person. Um, Talking about him, he did his ophthalmic residency at the University of Wisconsin in Madison, followed by a fellowship in pediatric ophthalmology and strabismus at the Bascom Palmer Eye Institute, Miami, Florida. Subsequently, he returned back to the University of Wisconsin, where he has been on the faculty since 1974 and has been the director of the Pediatric Eye and Adult Strabismus Clinic. He is currently Professor Emeritus in the Department of Ophthalmology and Visual Sciences at the University of Wisconsin. Dr. Kushner has been the secretary for the program of APOS, editor-in-chief of the Journal of Pediatric Ophthalmology, founder general, editor of the Journal of APOS, and editor-in-chief of the journal Binocular Vision and Ocular Motility. He has published over 200 peer-reviewed manuscripts, authored 41 textbook chapters, edited 3 textbooks, and has been the sole author of another 2 textbooks. The vast majority of these publications have dealt with strabismus and disorders of binocular vision. Dr. Kushner has given 24 named lectures and received many awards, including the Heed Award, the Bressler Prize, and the Senior Honor Award from both the AAO and the APOS. He has been listed in every annual edition of the Best Physicians in America since its first publication in 1993, and was listed in 20 most innovative pediatric surgeons alive by top masters in healthcare administration. We look forward to hearing from our esteemed guest and speaker, Dr. Burton Kushner, who is going to be talking to us on 2 very relevant talks. One, a comprehensive approach to vertical strabismus, and the second talk on resurgeries in strabismus, my preferred approach. We look forward to hearing from you, Doctor.
Well, thank you so much for that lovely introduction, and thanks to all the attendees who are giving up an evening to hear this. It's an honor to be here. So I'm going to start with trying to get my first presentation shared. Take me just a second to go to screen share. And we're going to do this. And now I think we're good to go. So I'm going to talk about what I'm calling a comprehensive approach to vertical strabismus. And by that, I'm going to talk probably for the majority of the talk on diagnosis, but we will also get into some treatment, which could be a separate talk in and of itself. And I wanted to start with a video of this particular patient who I saw back in the 1970s. And this is a man who, for reasons you'll see, really got me interested in this topic. He's a very well-known professor on campus here in Madison. He actually is a Nobel Prize winner, very distinguished person. And there was this day that I was operating, I was scrubbed doing surgery, and I get a message, someone comes in the room and says that this well-known professor is in the emergency room. He had been in a motor vehicle accident. He momentarily lost consciousness. He woke up and he sees double. So I'm scrubbed. So I send my resident to go down and at least do a preliminary evaluation and give me an idea what's going on. And he comes up and he says that this professor appears to have a left superior oblique palsy. He has a left hyper and it's bigger on right gaze and left head tilt. So let's just take a look at this.
This man developed double vision after a motor vehicle accident. He has a left hypertropia, which increases in right gaze. It also increases on left head tilt, meeting the 3-step criteria for a left superior oblique palsy. In fact, he has an orbital floor fracture in the right eye and fixes with the right eye because of mild amblyopia in his left eye.
So this is one of the many examples of what I'll call errors in the three-step test. And the three-step test, which everybody seems to go to as their first thing to do in evaluating vertical strabismus, is predicated on the assumption that there's a palsy of one vertical muscle. And of course, there are a lot of conditions causing vertical strabismus that are other than a palsy of one vertical muscle. We just saw an example of a restriction. Multiple muscle involvement will be fooled by the three-step test. Here's a classic example of a right superior oblique palsy by the three-step test. It's a right hyper, it increases in left gaze, it increases on right head tilt. Superior oblique palsy. But if we fill in the missing fields, we see that up here in the field of the left inferior oblique, there's a left hyper. And if a patient has a reversal, if they have a left hyper in any field of gaze, and including on head tilt, you must be dealing with something other than just a palsy of a depressor in the right eye. And we can also see the torsion that this patient has, totaling 17 degrees between the two eyes, is more than one would see with a superior oblique, unilateral superior oblique palsy. This is a patient with a bilateral superior oblique palsy, and a three-step test is not going to be able to tell you that. Again, it assumes that there's a palsy of one muscle. Prior surgery. Well, if a patient has a weakness of whatever muscle and you go in and you operate and you recess or do whatever to other muscles, now you have multiple muscle involvement. And again, three-step test is not gonna, three-step tests actually have no use in a case of prior vertical surgery. DVD. DVD classically behaves opposite of a superior oblique palsy on the Wilczewski head tilt test. So this is a photo showing the classic example of what DVD does. He's got a small left hyper here in primary. It increases on right gaze. Now, if this was a superior oblique palsy, it would increase on left head tilt. DVD will classically increase on contralateral tilt. Here you see a bigger left hyper on right head tilt. That's what's classic. That's what's described in the literature. But actually, in a prospective study that we looked at, only 57% of patients in our study with DVD behaved in this classic manner. This video will give an example of the class.
This woman has DVD greater in her left eye than her right. She shows the classic response to head tilt. Her right DVD increases on left head tilt, and her left DVD increases on right head tilt.
So that's the classic response. Now, in this prospective study, we found that 19% of patients, almost a fifth, behaved atypically. They increased their hypertropia, tilting the same way that a superior oblique palsy would. And in 24%, there was either no change on head tilt or it increased on both right and left head tilt. And when we looked carefully at these patients, we could not determine any specific diagnostic criteria that would predict which ones would behave in one manner or another. So all I can say is with DVD, if you determine DVD is present, three-step test is not going to be useful in any way at all. Skew deviation. Skew deviation will give an erroneous answer on a three-step test. Again, it's not a palsy of one vertical muscle. Think of a skew if you're seeing torsion that doesn't fit with the motility pattern that you see. And then, of course, there's the supine head tilt test, which is not new, but relatively recently described, popularized by Agnes Wong, where the hyper decreases substantially when the patient is put in a supine position. Skew will not be diagnosed with a three-step test. Myasthenia. Myasthenia can mimic anything. You can have a myasthenic cerebral palsy. You can have a myasthenic palsy of any vertical muscle. And I suppose in that case, you may say, well, the three-step test may, in fact, diagnose a cerebral palsy, but or whatever the condition is. But that's not really the underlying diagnosis. You have to think of myasthenia separate from the test. And then the last thing in this list that I want to talk about are these small hypers that occur with horizontal deviations. You have a patient with, maybe 30 prism diopters esotropia, and they've got a couple prism diopters of hyper, and it increases a little bit on head tilting one way or the other. And there's an explanation for these deviations as to why they will increase or decrease with a head tilt test. This is a schematic of a patient with an esotropia. And let's say there is a small vertical, be it hyper or hypo, doesn't matter for the discussion. And let's assume that the vertical muscles are completely normal. When this eye is esotropic, it's more in the field of the superior oblique than the superior rectus. So if there's the normal increase in tonus or decrease in tonus to the superior rectus and the superior oblique with head tilt, you're going to have a decrease in a hyper of this eye or an increase in a hypo. And conversely, if the eye were exotropic, the eye is more in the field of the superior rectus muscle. So on right head tilt, you'll have a small increase in the hypertropia. And again, you don't want to rely on the three-step test for that diagnosis. Now, it's also recognized, and not widely published, but has been published, that the three-step test is notoriously inaccurate for vertical rectus palsies. And there's a possible reason for this, which I'll demonstrate. It turns out, and this is work that N Palsy did, and he kindly gave me a copy of this video that he took, which I'll show in a minute. He determined that the inferior oblique alone, if you detach the superior rectus, the inferior oblique alone is working, it can't elevate the eye above the midline. And the superior oblique by itself, if you detach the inferior rectus, can't depress below the midline. And both of these things would be required by the three-step test in a vertical rectus palsy. So let's look at this video. This is N Palsy operating. It's not perfect quality. This was originally shot on 16 millimeter film and then digitized, but it'll show you what I want to show you.
This shows someone undergoing strabismus surgery under topical anesthesia. The head is at the top of your screen. Vertical saccades are normal. The superior rectus muscle is disinserted in the usual manner. Testing shows the superior rectus is completely detached from the globe. Afterwards, the eye can make brisk saccades from below to the midline position, but cannot elevate above midline.
So that is very likely one of the reasons that three-step test is not really accurate and can be relied upon when testing for vertical rectus palsy. We often think in terms of weaknesses of muscles, but there are circumstances where there can be overactions. This is a patient that has a left superior rectus overaction. It actually came as a result of a marking injection causing a hypertrophy of the left superior rectus. And the three-step test will be inaccurate here because it'll assume that there's a palsy, but you'll see the difference on head tilt. Now, this one I do not think has audio, so there's very minimal hyper, but it increases, it comes out a little bit on left gaze. And you'll see on her versions, right eye gets up okay, it's not an inferior rectus restriction. but the left eye, that superior rectus clearly overacts. And imaging, in fact, confirmed that she has a toxicity hypertrophy of the superior rectus in the left eye. So again, three-step test assumes it's a palsy. Okay, I want to move away a little bit from the three-step test and just go over some other aspects of diagnosis. So we look at a patient like this, and common terminology is to call this an overacting right inferior oblique. But is it really? The term overacting inferior oblique implies an etiology. It implies the reason that right eye is higher is because there's overaction of that inferior oblique muscle. And it would probably be better if we use the more generic terms over elevation or over depression in adduction until we've actually sorted out exactly what is causing the appearance. So here's a girl. This actually is the index case of this entity that I've referred to as just pseudo inferior oblique overaction. Let's take a look at her.
This girl was asymptomatic but found on routine exam to have this impressive motility disorder. There is a Y pattern with marks splaying out of each eye with elevation in adduction. It resembles inferior oblique overaction. However, despite this significant apparent inferior oblique overaction, there is no superior oblique underaction, no elevation on direct horizontal side gaze, and no fundus torsion. This is pseudo-inferior oblique overaction.
This is a very interesting entity. And this girl, by the way, she was totally asymptomatic. Her parents never noted this problem. She was 6 years old, and she accompanied her parents and her brother, who was a strabismus patient of mine, on one of his visits. And the parents said, "Should we have our daughter examined too?" And I said, "Well, do you see a problem?" They said, "No." I said, "Well, let me just take a look at her." And I had her go through versions. And there's this, 60 prism diopter, exo, and upgaze, never noted by the parents. She was 6 years old when she was first diagnosed. She works in my hospital. She's a nurse, and I still see her. She's about 35 years old now. Never changed, never symptomatic, never needed anything done. This is actually a variant. There are two things that cause this. The most common ones that I've seen are variants of Doyen's syndrome, where there's a co-contraction of the lateral rectus on attempted elevation. And the other thing is polyheterotopia, which was not an entity I even knew about back in, we didn't know about in the 1980s. When this child was first diagnosed. And the important caveat here is that it's been determined that weakening the inferior obliques do absolutely nothing to correct this pattern. If you need to treat it, raising the lateral rectus muscles can be effective. This is the anti-elevation syndrome, and just looking at that, you'd say it's an overacting right inferior oblique, but it's not.
When viewed on elevation and side gaze, this girl appears to have inferior oblique overaction. In fact, she has bilateral anti-elevation syndrome. As an infant, she underwent bilateral inferior oblique anterior transposition, placing them anterior to the inferior rectus insertion. What looks like inferior oblique overaction is over-elevation due to fixation duress. The abducting eye is restricted to elevation in abduction.
So this also is the index case. I did not do her original surgery. I never put the inferior oblique fat fire anteriorly, but she came to see me when she moved to Wisconsin from her home state of Texas. So this is what causes that. This is an anteriorly transposed inferior oblique muscle. And you can see that if you think of the neurovascular bundle, which is taut, as the functional origin of this part of the muscle, you will have the most restriction to elevation in abduction. When the eye is in abduction, visual axis is parallel with these anterior fibers. And that's the anti-elevation syndrome. Duane syndrome, I mean, if you just look at that picture, you'd say overacting inferior oblique, perhaps, unless you note the narrowing of the fissure.
When viewed in left gaze, this looks like an overacting right inferior oblique. In fact, this girl has Duane syndrome in her right eye. There is limited abduction of the right eye, and on adduction above the midline, there is an upshoot, and on attempted adduction below the midline, there is a downshoot of the right eye. On adduction, classic globe retraction can be seen.
So very classic for Duane's, particularly exotropic Duane's. And then perhaps finally, there are pulley issues. This is a boy, he was 16 years old, and he, for reasons that aren't still clear, started developing double vision in left gaze. And you see he looks pretty good straight ahead here, but in left gaze, he has this hypotropia of the left eye and a little limitation of elevation. These are his orbital scans, and you'll see that the left lateral rectus is low. A line through the top of the lateral rectus in the left eye bisects almost near the middle, the lateral rectus in the right eye. He developed this muscle slippage or pulley slippage. I don't see a dehiscence of the band between the superior rectus and the lateral rectus like we do with the sagging eye syndrome, but nevertheless, he had that. And he was helped by elevating and fixating the lateral rectus at the equator in an elevated position. And then just some other examples of DVD. I showed you what they do on head tilt, but DVD will also increase in adduction. And it's thought, I don't know if I believe this completely, but it's thought that the nose acts like an occluder and that causes the eye to go up. So the question is, how can you tell when an eye elevates in adduction if it's an overacting inferior oblique or if it's just DVD being manifest? Let's take a look at examples of both.
This boy has over-elevation of either eye on adduction. Cover testing in side gaze does not show a hypotropia of the abducted eye. This over-elevation is due to DVD. Contrast that with this boy. He does show DVD in primary gaze. He also shows over-elevation of either eye on adduction. However, in this child, cover testing in side gaze shows a hypotropia of the abducted eye. This boy has true inferior oblique overaction coexisting with DVD.
So that's the key in this. DVD with no inferior oblique overaction may elevate in adduction, but on cover test, you don't see a hypo of the other eye. If there's true inferior oblique overaction with the DVD, there is. And that's an important differentiation because the treatment for DVD, at least in my hands, and we'll talk over some treatment principles shortly, is different if there's true inferior oblique overaction. Okay, a word about torsion. There are two types of torsion. There's objective, which is an assessment of the actual anatomic appearance of the eye. And that's depicted here. The normal relationship of the fovea is to lie between a line level with the bottom of the optic nerve and a line at the junction of the lower third and upper 2/3 of the optic nerve. So that gives us a range of about 8 degrees for the normal position of the fovea. So if a patient perhaps started out with the eye right on the border for intorsion and developed a superior oblique palsy, and they developed, let's say 7 degrees of torsion, they might still end up in the normal position. They might be on the border for extorsion. So you can't determine the exact amount of torsion by looking at the fundus, but you can tell if it's significantly extorted or intorted, and you can compare it before and after surgery or from one visit to the next. Here's an example of an ex-cyclotorted fundus. The fovea is well below the bottom of the optic nerve, and here's an in-cyclotorted fundus where it's above that junction of the lower third and upper 2/3. So the role for objective torsion, in my mind, is it better identifies which eye has the problem, because sometimes patients will localize their subjective symptoms to their preferred eye. It just gives you a better idea of what's actually going on with the muscles. Whereas subjective torsion, that's the double Maddox rod or the synoptophore, if you use that, is better for telling something different. And that is, it's less apt, less accurate in identifying which eye is torted, but it's better identifying symptoms that need treatment. So I use fundus torsion to help me sort out what's really going on, which muscles are involved, which eye is affected. But subjective torsion tells me if I need to do anything. I mean, our typical, infantile esotrope or partly accommodated esotrope may have marked inferior oblique overaction. If they have no subjective torsion, you don't have to address the torsion unless you need to in order to address their motility. But as far as it being a symptom, it doesn't have to be addressed. Now, classically, the double Maddox rod test is done with a white and a red Maddox rod, and studies been shown that was fairly convincing to me that subjects will often tend to subjectively normalize the image in the eye that has the white lens in front of it, regardless of whether that's the paretic eye or not. And you do decrease that artifact if you use 2 red lenses, and that's what I have shifted to do. And then one of the final things with diagnosis is whenever you're seeing a patient that has unequal vision, always consider the possibility that they're fixing with the involved eye. That first patient I showed you with the orbital fracture in his right eye fixed with that eye because he was a 20/40 amblyop in his other eye. Here's another example. This is a right superior oblique palsy in a patient who fixes with the right eye because of amblyopia in the left eye. And this has been named the fallen eye syndrome. You'll see there's a left hypo. Let's see if we can get this to go. And there's no audio on this, so I'll just talk through. There's a left hypo, and it's greater in right gaze. And on left head tilt. I'm sorry, right head tilt. So this right head tilt. So this, other than the fact that fixed with the right eye, meets all the criteria for superior oblique palsy, fundus torsion in the right eye, and so on. And I've seen patients with vertical strabismus that fixed with the involved eye with virtually every vertical condition you can imagine. I've seen it with Doyen syndrome. I've seen it with Brown syndrome. I've seen it in patients with Graves orbitopathy. I've seen it in monocular elevation deficiency. So always just pause. And when you have a patient with amblyopia, just ask yourself, might that be what's going on? So this is also a borrowed video. This is from Dave Guyton. Now this is an operating room maneuver, but exaggerated force ductions will tell you if the oblique muscles are involved. And I'm going to run this video, and this is Dave Guyton operating.
We're going to be seeing the left eye of a patient seen from above. Horizontal force ductions in the usual manner are normal. To test for torsional restriction, it helps to retropulse the globe, which puts the oblique muscles on stretch. Rotary force ductions can be done in this manner to look for a torsional restriction. Look for symmetry. To test for oblique muscle tightness, grab the eye at 3 and 9 o'clock. For the superior oblique, push the nasal force up into the superior nasal quadrant and rock the eye temporally in this manner. You can see and feel the eye roll over the superior oblique tendon. For the inferior oblique, do the same in the inferior nasal quadrant. This amount of tightness is normal. We are now going to see a patient with superior oblique overaction and a pattern. When testing for the superior oblique, you can see this marked 3+ restriction as the eye rolls over the tight superior oblique. The inferior oblique is normal. Look at the eye just snap over the superior oblique. Bilateral superior oblique tenotomies were performed and the maneuver repeated. The eye now moves freely when testing for the superior oblique, indicating that the tenotomy was complete.
So that's basically the technique of exaggerated force ductions. I and most others have now changed since this video was made, to just using one forceps in the superior or inferior nasal quadrant. It works just as well. Okay, we're going to move on a little bit to treatment. It's obviously a very large subject, and I'll just address a couple of issues. Some general principles. When treating vertical strabismus, particularly in a patient that has diplopia awareness, you want to, above all, not overcorrect primary position and the down gaze reading position. You want to choose muscles that will match the pattern. In other words, you want to weaken or tighten muscles that will give you the most correction in the field of gaze that's most important, but not compromising primary gaze or reading position. You want to consider torsion if the patient has diplopia awareness in your choice of muscles. And in general, you can weaken yoke muscles unless the eye with restricted movement is -3 or -4, in which case weakening yoke muscles may not get you what you want. So we'll talk about fourth nerve palsy. And this is just my approach. It's not the only approach, but it's what I've used. The first thing is I dichotomize whether I'm going to do a 1 muscle or 2 muscle procedure. I almost never do 3. And I make that distinction based on the primary position measurement, because I do not want to overcorrect primary, regardless of what their deviation is in side gaze. So in general, if there's under 15 in primary, I'm going to do a 1 muscle procedure. And if there's 15 or more, I'm probably going to do 2 muscles. And if it's an old enough patient I can do adjustable sutures on, I don't do them in children, I may have that cut off at about 12 prism diopters for doing a second muscle, because I can use an adjustable. So let's say it's under 15 prism diopters. That's a 1 muscle procedure. We're talking hypothetically about right eyes here. And let's say the deviation's biggest up in the field of the right inferior oblique, 3+ here and only 1 down here. I'll weaken the inferior oblique. Let's say the deviation's biggest all across the adducted field, is big up and down. Well, if it's under 15 in primary, I'm still just going to do 1 muscle. I'm going to weaken the inferior oblique. What if it's biggest down in the field of the superior oblique? Well, this is your classic position for doing a superior oblique tuck, and I think that's an effective procedure. But for people that aren't comfortable doing superior oblique tucks and don't do it very often, you can almost always avoid doing a tuck by recessing the contralateral inferior rectus, in this case would be the left inferior rectus, and nasally transposing the right inferior rectus to address the torsion. And I would say in my protocol or schema, tendon laxity does not really play a role in whether or not I do a tuck. If I'm going to do a tuck, a lax tendon means do a bigger tuck, a taut tendon means do a smaller tuck, but it doesn't tell me that I need to do a tuck. So what do we do if the deviation's greater than 15? Well, deviation's biggest up in the field of the inferior oblique, I'll do the inferior oblique and the contralateral inferior rectus. I'll do the same thing if the deviation is biggest across the adducted field, and I'll do the same thing if it's biggest in the adducted field and across the bottom. So that's basically what I'm doing in almost all two muscle procedures, with one exception. If I've got more than 10 prism diopters of hyper in the ipsilateral adducted field, that to me means there's probably superior rectus overaction or contracture. And in that situation, I'll do the inferior oblique and a very small right superior rectus recession. Small because weakening both elevators at the same sitting will cause an overcorrection. Now with DVD, I dichotomize treatment based on whether it's bilaterally or unilaterally manifest. The most common presentation for DVD is to have it bilateral, but only spontaneously going up, manifested in one eye and latent in the other. So if it's bilaterally or unilaterally manifested, I look at if it's bilaterally unilaterally manifested, but bilateral, do they have equal vision? Is there potential to shift fixation? If there is, I'll do bilateral surgery, even if it's only manifest in one eye. If they're amblyopic in one eye, I'll do unilateral surgery. And if inferior oblique is present, overaction is present, as evidenced by X-cycled torsion of the fundus, that influences me too. So bilaterally manifest, I'm always doing bilateral surgery. Unilaterally manifest and contralaterally latent, if there's equal vision, I'll do bilateral surgery. Unequal vision, I'll do unilateral surgery. If inferior oblique overaction is absent, I'll do superior rectus recession. If inferior oblique's present, overaction's present, I'll do bilateral inferior oblique anterior transpositions. If it's a unilateral case, I'll do a unilateral superior rectus recession because I do not like the anterior transposition procedure done unilaterally. It causes an objectionable narrowing of the palpebral fissure, which is notable if it's a unilateral operation, and a hypo in up gaze. To avoid the anti-elevation syndrome, I have switched to only suturing the anterior nasal corner of the inferior oblique to the globe and letting the posterior lateral corner just hang back. And thus far, I've never had an anti-elevation case using this technique. Now, it's a trade-off. That's a weaker procedure for DVD, but it does avoid the anterior elevation syndrome. So we've gone over a comprehensive approach. We've talked about history, fixation with the involved eye. The pattern helps with the diagnosis, three-step test errors, these treatment principles, which I just gave you. Just a couple of soft signs and then we're done. If the incompetence pattern is larger vertically, there's a bigger deviation between down gaze and up gaze, think of a rectus restriction. A rectus problem or a restriction. If the incompetence pattern is larger horizontally, bigger from right to left gaze, think of an oblique problem. And if the forced head tilt difference is large, think of an oblique problem or DVD. If it's small, think of a rectus problem or most other causes. This is the largest head tilt I ever saw. This girl would keep her head straight. She was very young in this picture. And with visual effort, she almost had her head sideways. And with that, I thank you. So that's the end of the first presentation.
Dr. Burton Kushner, can we thank you so much for the presentation. Can we take a few audience questions?
Yes.
Can we take a few audience questions? I mean, we have some questions on the from registered delegates on this. So would it be okay if we do a couple of questions and then move on to the second talk?
Yeah.
Okay, so we have one question, that is how reliable is torsion in distinguishing pseudo inferior oblique overaction from true inferior oblique overaction?
I'm going to repeat the questions. The audio is not always great on my computer. How accurate is fund distortion in telling true inferior oblique overaction from pseudo inferior oblique overaction? Is
Yes,
that the question?
yes.
Yeah.
Yes, that is
so in pseudo inferior oblique overaction, like the case I just showed, there is no fund distortion. That's one of the diagnostic criteria. If there is fund distortion, then there is probably true oblique overaction. And if there is true oblique overaction, unless it's a trivial amount, there should always be fund distortion.
We have one more question.
Yeah.
So we have two or three questions, and then we move on to the next. So we have a patient with monocular elevation deficiency, and the hypotropia in the involved eye is more than 30 prism diopters. The forced duction testing is negative for elevation. How would you manage?
Monocular elevation deficiency, hypo in primary.
Hypo in primary is more than 30 prism diopters.
Well, that's, we use the term monocular elevation deficiency to cover a number of things. This is obviously not one of the supranuclear, quote, double elevator palsies. It's probably a superior rectus paresis. Many of the ones that look like monocular elevation deficiencies are inferior rectus restrictions, but in your patient, the restriction, the forced ductions are normal. So I tend to do a classic NAP procedure in these situations. I do a full transfer of the medial and lateral rectus muscle up to the superior rectus, and I've been satisfied with those results. If 20 is fairly large, I think I would still limit it to that. If that undercorrected the patient, I'd probably go to doing the superior rectus in the other eye as a secondary procedure. But that would be my first approach.
We have a few more questions. One is, what is the role of the frenulum of the superior oblique when it comes to large superior rectus recessions or in superior oblique surgeries? The role of frenulum of the superior oblique.
The role of what?
Role of the superior oblique frenulum in superior rectus surgeries. Like for DVD, because the recession has to be large, 10 millimeter like that. So would you lyse the frenulum when you're doing large recessions to treat dissociated vertical deviation?
So my approach with DVD, again, if it's either bilaterally manifest or there's unilateral manifest but equal vision, so the patient may switch eyes, I'll do bilateral surgery. If there is inferior oblique overaction, I'll do inferior oblique anterior transposition. If there's no inferior oblique overaction, I'll do superior rectus recessions. Now, the question as to the amount of the superior rectus recession, it's not so much formulaic. You really have to do large amounts. If I'm doing bilateral surgery, and then I will do an asymmetric amount in each eye, depending on the size of the manifest of the total deviation in each eye. And I'll usually do 2, maybe 3 millimeters different. So I may do 9 in one eye, 6 in the other, 10 and 7, something like that. If it's approximately equal, I'll do the same in both eyes. If I'm doing, I probably should have talked about unilateral first. So the formula that I have, if I'm doing unilateral surgery, that would only be the patient that's amblyopic in the other eye, and they're not going to ever shift fixation. I do something like about maybe 5 millimeters for 15, adding about 1 millimeter every 5 prism diopters. So I'm going up to about 7 or 8. I don't use that same formula for bilateral surgery because if I'm weakening the superior rectus in the fixing eye, that's going to in somewhat negate the surgery I'm doing in the other eye. So that's when I go to the very large bilateral, 9 in both, 10 and 7, something like that. Does that address the question?
Actually, 2 more related questions. One is because you are doing superior rectus recession of 7-8 millimeter, would you cut the frenulum of the superior oblique that connects the 2 muscles?
Yeah, the frenulum is it's an interesting topic in and of itself, and we did do a study actually looking at the behavior of the frenulum. For recessions up to about 8 or 9 millimeters, as the superior rectus goes back, the frenulum goes back with the muscle. So you don't have to sever the frenulum. Now, if you do sever the frenulum, and then you're putting the muscle back, let's say 9 millimeters, the muscle is going to be right on top of the superior oblique, and you can end up with it not adhering. You could, I suppose, use non-absorbable sutures, but I prefer to not do that. So on superior rectus recessions, like to leave the frenulum intact. On a resection of the superior rectus, I don't want to pull the frenulum forward. So I will then tend to separate it so it stays back while I pull the muscle forward. Okay.
In unilateral inferior oblique overaction and DVD, you said you would avoid an inferior oblique anteropositioning. So unilateral DVD and unilateral inferior oblique overaction, unilateral manifest DVD and unilateral inferior oblique overaction. So what?
So if I had pure, if I knew I was going to be doing unilateral surgery, so DVD is almost always bilateral. I mean, if you look really carefully, you'll see it in the other eye. The issue that determines bilateral or unilateral surgery, in my mind, is are they going to shift can they shift fixation? If you do a substantial procedure in the fixing eye, in the deviating eye, and there's good vision, they will very likely start fixing with that eye, and the other eye starts going up. So, but if there's amblyopia, so I know they're not going to shift fixation, and there's unilateral inferior oblique overaction and unilateral DVD, I avoid doing a unilateral anterior transposition. There are a lot of people that do it. I've seen too many patients that don't look good afterwards. It doesn't. I actually had a patient come to see me where 15-year-old girl, her chief complaint was her left eye looked smaller. She had a narrow palpebral fissure. Someone did an inferior oblique transposition in that eye. And it's cosmetically noticeable. Not noticeable so much if it's done bilaterally. And on elevation, which I realize isn't always such a big cosmetic issue, there's almost always a hypo. So I essentially never do the inferior oblique anterior transposition unilaterally. Now, I suppose if there was really a big element, I've never had to do this, of inferior oblique overaction where I was concerned if I did a unilateral superior rectus recession and there'd be a hyper and adduction, you could do a standard inferior oblique weakening procedure in addition to the superior rectus. I mean, I could imagine a hypothetical situation where one might do that, but I can't recall that I've ever done that.
Hamid, you have any questions?
So, what is your experience on inferior rectus plication in DVD?
I actually personally have very limited experience with inferior rectus, either resection or plication. I know plications are replacing resections in a lot of people's hands, but that's really in more recent years. And as I said earlier, I retired from doing surgery for a couple of years. So I know that Marshall Parks used to like doing inferior rectus resections, or I presume today it would be plications for DVD. It's never been my go-to operation. So that's kind of the only time I've done that is on re-ops where the other standard things have failed. And usually, which of course does occur with DVDs. So, but I don't have any experience with doing it as a primary procedure. In general, I don't like, quote, strengthening or tightening operations as much as weakening operations. I just think they're less predictable. The muscles stretch out, sarcomere remodeling occurs, and you lose the effect over time. But there are people that do it and get good results with it.
And one last question, sir. What is the treatment you do for DVD with superior oblique overaction?
DVD with superior oblique overaction. Fortunately, I don't see that often. You have to decide how serious. I mean, most of these patients with DVD are not bifoveal fusers. So if you leave the patient with a bit of an A pattern or something, that's not going to necessarily be that bad. But if it's marked and you feel for whatever reason you need to do it, very big A pattern, perhaps a cosmetically noticeable vertical deviation in adduction, I think you have to do both. You weaken the superior obliques and weaken the superior rectus muscles. At least technically, you're in the same area and you can do it. I have not had to do that in all that many. I've certainly done it, but it doesn't come up that often. The concern is weakening the superior oblique may make the DVD worse because it's a depressor. So you're going to have to increase your surgical formula for the superior rectus recession. Should we go on to the other talk then?
Sure, we can.
Okay. And as with the other, it'll just take me a minute. So we're going to do this, and hold on, I just lost my screen. There we are. Screen share. This, that, and okay. So we're going to talk about reoperation strategies, and I've titled this Cooper's Dictum Amended, and perhaps that's a misleading title because people don't talk about Cooper's Dictum so much now as they did earlier in my career. But it's something that often comes up on panels when we're at the APOS meeting or one of the international meetings, and someone presents a case and it's a reoperation. Someone will kind of mumble Cooper's Dictum and act accordingly. And I'll explain what that is in a minute. And I like this quote from some unknown author: view every failure as a substantial discovery in a mission of trial and error. I think that's very apt for reoperations. So Cooper's Dictum, as this was Ed Cooper, who was a strabismologist from Michigan, is often quoted or misquoted, I'll say, that when doing a reoperation, approach it as a fresh case. In other words, you've recessed the medial rectus muscles and now the patient's exotropic. Do you go back and operate on those medial rectus muscles you recess, or do you just do the laterals and not alter your formula? And people always say, Cooper's Dictum said, just treat it as a fresh case. Patients now with 30 diopter, prism diopter exotrope, recess the lateral rectus muscles what you would do for 30. In other words, don't make allowances for what was previously done. And in fact, there are many, many exceptions to that. And it turns out, I find it interesting often if you go back and look at the original literature that is quoted, you'll find that Cooper is always, this dictum is always misquoted. It was taken out of context. He said it in the narrow context of a discussion about routine consecutive exotropes. He said, if you recess the medials, you know, whatever, now the patient's exotropic, if it's routine, you can just treat the laterals as you would for that angle of exotropia. Now, he said this at a time when the common teaching, the common precept was you should always advance the medial rectus muscles in that setting and avoid doing the laterals. So people just misquote him all the time. I'm sure he'd be turning over in his grave if he knew how he was misquoted. What Cooper actually said, and we're not going to spend a lot more time on Cooper, whenever an overcorrection results from muscle surgery, the case should be reevaluated on the diagnostic findings after the last operation. It's inadvisable to assume one should always undo the prior surgery. The idea that surgery for consecutive exotropia should always undo what was previously done should be rejected. So this is one of many examples where people are quoted clearly out of context. On the other hand, what he advised is that if a consecutive exotropia shows a convergence insufficiency pattern, which he takes as a soft sign for underacting medials, the medial should be advanced. So he's saying in these cases, don't treat it as a fresh case. And it's important to note also that when he wrote this, the maximum people were doing for medial recessions was 3.5 to 4 millimeters. So certainly if you had a convergence insufficiency after that, you probably had slipped or lost muscles. So I'd amend Cooper's dictum and say there are many exceptions, and exceptions include if there's a restriction from previous surgery, you've got to address that. If there's lost, slipped, or weak muscles, stretch scars, you've got to address that. If there are distance near differences, convergence insufficiency or divergence insufficiency suggesting the operated muscles are weak, you want to go to them, and if there's any incompetence. So the amendment to continue would say when doing a reoperation, approach it as a fresh case, except when you shouldn't. And there are a lot of cases where you shouldn't. So a general approach to reoperations, first pearl, it's not formulaic. Be prepared to alter your plan. And I'm always a little, I don't know, amused when, you know, a former fellow or a colleague will write me and they'll talk about a patient that's had prior surgery and they'll want to know how many millimeters they should do on whatever muscles. And unless it's really a competent, looking like a fresh case, you have to be prepared to alter your plan. I love this quote from a comedian in the United States. If you want to make God laugh, tell him about your plans. And I think that that is very appropriate for reoperations. So when planning reoperations, the first thing I'd say, I really try to get old records. They can be very helpful. I've argued with some colleagues. They say, well, I can always do a surgical exploration. I can see where the muscles are. No, not necessarily. I recall one patient that prior records showed, it was a patient with Doyen syndrome, had a posterior fixation suture placed in the medial rectus, 12 millimeters back from the insertion. If I was reoperating that patient and I didn't know to look that far back, normally I wouldn't go that far back. I wouldn't know there was a posterior fixation, and that would completely negate anything I did to the anterior part of the tendon of the muscle. If there was a myectomy done of the inferior oblique as opposed to recession, I want to know that if I'm planning an inferior oblique anterior transposition. it's helpful to know if there was an over or under correction that I'm dealing with. In other words, am I dealing with a consecutive or a residual deviation? Because that's going to influence whether I can operate fresh muscles or reoperate previous ones. If I have an undercorrection and there was substantial recession done on, let's say, the medials for an ET, I may not want to put them back further. I'm going to go to the laterals. But if I have an ET and they previously had exosurgery, I've got a lot of room to run on the medials. And it's nice to not have to explore muscles that you don't need to explore. Now, I find that even if you can't get actual surgical records, at least the patient's parents or old photographs will at least show you if they were esotropic or exotropic before the prior surgery. I want to know if there was a vertical deviation and a vertical surgery was done. If I have a patient with a vertical deviation now and their prior surgery was just horizontal, I may be dealing with, let's say, an inferior oblique incarceration because the lateral rectus was resected. If they have a scleral buckle, there may be incarceration of an oblique muscle. And I want to know if surgery was done on a hangback. If it was done on a hangback on the superior or inferior rectus and it's underacting, I may be dealing with non-adherence. So I find old records helpful. So the first decision I have to make in a reoperation is, am I operating fresh or previously operated muscles? And I follow this schema, and we're going to go through this a little bit at a time, so you don't have to try and take this all at one time. The first question I ask is there a limitation of rotation? And we're going to, that's yes or no. So let's say yes. Limitation of rotation, situations, it's a closed deal. I'm going to operate previously operated muscles. Unless, of course, there was a limitation of rotation before that prior operation. Okay, here's an example. This is a girl with a big exotropia of the left eye, and the eye does not adduct. And this is a scan. Now, in abduction, her lateral rectus muscle looks pretty normal, but in adduction, you see this very classic appearance for either a slipped muscle, slipped in the capsule, or a stretched scar. And the appearance is you've got this very thin band of connective tissue anteriorly and a large fusiform swelling posteriorly. And that's what happens on a dynamic scan, dynamic meaning the patient's looking right and then looking left. And in the attempted field of action of the weak muscle, you see this configuration. You know you're dealing with a stretched scar or capsule if the muscle looks reasonably normal in the opposite field, in this case in abduction, as you can see here. Now, this picture is very similar looking to something that I have called the collapsed empty channel sign. This is a muscle that looks very much like the one you saw. But the difference is this muscle looks this way with the eye in neutral gaze. It's not attempting adduction. And when you see this in neutral gaze, or even in this case, in abduction, very often this tissue here is an artifact. And this can be a completely lost muscle. And what my neuroradiologist tells me is that if the muscle is off the globe, it retracts in, let's say, a channel, and the two opposing faces of orbital connective tissue come together and create an interface that looks like this on imaging. And when you go in, there's nothing there. And I tumbled to this when I had gone in on, I've had a number of cases where the scan shows me, well, the muscle's attached by this thin connective tissue, and I can't find it. So this is something to think about. This is actually a lost muscle. The difference being, this is the eye in primary gaze as opposed to adduction. The opposing interfaces show up on MRI and no muscle attachments found. Okay, back to our flow chart. Limitation of rotation. There's no limitation of rotation. Then I want to know, is it an overcorrection or undercorrection? So let's say they're esotropic. Am I dealing with a residual ET or a consecutive XT? Let's look at that. So it's an undercorrection. They're ET, and we're ET, they're still ET. Undercorrection. If the prior surgery was near maximum, I'm not going to push them back further. I'm going to go to fresh muscles. But if the prior surgery was not near maximum, they were ET and medials were done 3.5 or 4 millimeters, I'll probably, or at least I can, go back and reoperate the previously operated muscles. No limitation, but an overcorrection. ET, now they're XT. I'm going to pay attention to whether they're comitant or not. Same at distance and near. If they were ET and now they're XT, and the XT doesn't show a convergence insufficiency pattern, I'll operate fresh muscles. I'll go to the lateral rectus muscles. But if the medials were done and now the near exceeds the distance by even a tiny bit, that's a soft sign for me of weak previously operated muscles. And I'm going to go back to those previously operated muscles. Okay, so here's the example I just gave, medials for ET, now XT, convergence insufficiency pattern. It's a soft sign for underacting muscles, and I think they must be addressed. I actually looked retrospectively at patients that I had operated that had XTs with very small convergence insufficiency patterns, and I got really less than the expected amount of effect by operating the lateral rectus muscles in those cases. So that's something to pay attention to. There are two caveats. One, no limitation, undercorrection, so ET still ET. Did 5 or 6 millimeters on those medials. I'm going to do the laterals, but I'll scale back just a little bit because I'm operating against weakening muscles, against antagonists that are weak. And I want to talk for a minute about exotropia, undercorrected XT, undercorrected, with lateral concomitants. That's where the deviation decreases in right and left gaze, both. This is a special situation. So let's talk about lateral concomitants, and I'm going to move away for a minute from reoperations, and let's talk about a de novo. So this is a patient who's 30 XT in primary, and in both right and left gaze, it decreases to 15. Now, this was described by Phil Knapp and Sally Moore back, I think, in the 1970s. They said that when you have an intermittent exotrope with this kind of lateral concomitants, they're very prone to overcorrection. And I think that's true. Not everybody agrees on how common this entity is. Knapp and Moore found it fairly common. Other people feel it's often an artifact of measuring a patient in side gaze and that it's not that common, but it does occur, and they're prone to overcorrection. So if you just look at this, you say, what mechanically can cause an exotropia to decrease in both right and left gaze? Well, there are only two things I can think of. One is if both lateral rectus muscles are weak, and the other is if the medials are tight or truly overacting. Now, if the patient's got an exotropia, I have a hard time fathoming that their problem is weak lateral rectus muscles. That just doesn't make sense to me. So I think this must be due to overacting medials. Usually they have normal force duction, so it's not tight medials. And then it makes sense. If the medials are overly strong and I weaken the lateral rectus muscles, the standard amount, and now I've got these overly strong muscles with weakened antagonists, the patient's going to go esotropic. So that's de novo lateral concomitants. That's what I just said. Now let's look at it after lateral rectus recession. Same thing, they're 30. I got a recurrence of my exo, and it decreases in side gaze. And they didn't have it before the operation. Well, this must be iatrogenically weak lateral rectus muscles. So these patients are not prone to overcorrection in primary. You don't have to worry about that. But they are possibly prone to overcorrection in side gaze because they have a smaller deviation. So you want to plan your surgery accordingly. Imaging may help with reoperations, and a few words about that. You must specify to include the orbit, because otherwise, I find when referring comprehensive ophthalmologists to order a scan, it's a brain scan, just one or two views of the orbit. You can't really tell much about the muscles. Contrast is not needed. Dynamic scanning, meaning multipositional, you look for primary gaze, right gaze, left gaze, to look for contractility of the muscle. And that's different from what some people call a cine MRI, where you take multiple cuts and link them together and make a movie out of it. You don't have to do that. That's more just research interest. MRI gives beautiful pictures. It's more expensive. It's harder on the patient. CAT scan usually works. It's thin cuts. It's faster. It's cheaper, but there's radiation. So you have to weigh the pros and cons of both. You want to talk to your radiologist, and ideally have a radiologist that really understands muscles. I can't tell you how many times I've seen scans read as normal by a neuroradiologist at other institutions where there was actually absence of one of the muscles or complete atrophy of one of the muscles. They're just not trained to know what to look for. And it helps if you have one radiologist you can work with, look at the scans together, you both learn from one another. That's how I learned about the empty channel sign, for example. And you have to review them personally, see them and go over them with the radiologist. So no special equipment is needed, but special instructions. So here's a case of how it can be helpful. Here's a 28-year-old woman. She had her ET surgery at a year of age. Medial rectus was lost during surgery. She underwent a transposition of the superior rectus and inferior rectus, big XT. She also, along the way, had a lateral rectus procedure, which I didn't write down. And she had no adduction and absent active force generation. So she came to see me, and I got a scan, and here is her medial rectus adherent to the orbital wall. But on attempted adduction, you can see that the muscle thickens. So it's still contractile. As an aside, this is the typical appearance of a stretched scar. As I showed you, it looks okay in contralateral gaze. And this is this is a result of her lateral rectus surgery. So we went in and found the medial, peeled it off the orbital wall, and got a good outcome. And she ended up with good adduction, and she's been stable for about 7 years, at which point she moved away and I lost follow-up on her. So a little bit about surgical dose after prior operations. Formulas are questionable, especially if you're talking about previously operated muscles, and adjustable sutures, I find, can be helpful. But a few caveats. Prior recessions, the muscles are, especially if a long time has elapsed, muscles become stiff, they shorten. So advancements or resections, or I could add plications, will have a bigger effect than normal. Prior recessions, you want to respect the arc of contact. Small re-recessions can have a big effect and cripple the muscle. So if the medials have been put back 5, you put them back another millimeter or 2, you may cripple the muscle. So it's a tightrope you walk between having just enough or too much surgery. And prior resections may have loosened. If you're operating on a patient and, let's say many years ago, the laterals were resected a lot, you may go back and find they're not tight at all. They stretch out and and become loose. I've often been asked, since people have moved to plications, is 1 millimeter of advancement the same as a resection or a plication? And the answer is yes, but only with respect to length tension. So when you resect a muscle, you're stretching it and you alter the length position on the length tension curve. And an advancement and a plication do exactly the same thing. But an advancement increases the arc of contact, and a plication or resection does not. So an advancement is a bit more powerful than a resection or plication of the same amount. I think resections and plications should be identical to one another. Okay, so now we're a little bit more with surgical planning. Be prepared to alter your plan. Expect the unexpected. Expect muscles not where they're expected to be, and expect that you may find prior surgery you didn't know about. A little bit about timing. When should you do it? In general, I like to wait at least 6 to 8 weeks if you have an adverse outcome. Exceptions would be if you recognize right off you have a slipped or lost muscle, or a very large overcorrection after a superior oblique tuck, or more than 5 prism diopters after vertical rectus transposition. And we came to 5 because studies show that if you have 5 on day 1, it doesn't go away, 5 or more. If I have these situations, I like to go back on day 1 or 2 if I can. But if I can't do it in the first week or maybe second week, I like to wait 6 to 8 weeks, because the worst time to go in is probably between about end of week 2 and 5. There's a lot more bleeding, a lot more edema, and you're probably better off waiting for everything to settle down. You can do surgery more predictably, and there's no particular advantage in doing it at 3 weeks versus 6 weeks. But in these situations, I'll go back right away if I can. So a little bit about technique. You want to do force ductions and repeat them throughout the procedure. When you find muscles, force ductions, detach muscles, force ductions, clean up scar tissue, force ductions, do them multiply. Consider a reverse leash restriction. So usually a restriction's opposite the field of limited gaze. If an eye doesn't adduct well, we think of restriction being laterally. But if you don't find restriction out there, or you free up out there and the eye still doesn't adduct, consider a reverse leash as depicted here. That scar tissue running from anterior in the orbit, posterior to the globe. So this is an eye trying to adduct, and here's a restriction nasally, a reverse leash that will limit adduction. So if you haven't freed up force ductions when you've taken care of it in the restriction in the area you expected, consider looking in the opposite field of gaze. One thing about reverse leashes is the restriction increases when you retropulse the globe. Rotary force ductions, I showed that in the video. Actually, you don't have to retropulse as much as was shown in that video, but rotate the eye clockwise and counterclockwise. First grab it at exactly 6 and 12 or 3 and 9 and look for symmetry. Here we can see I can rotate the eye further in this direction than this direction. That's a torsional restriction. Look for symmetry. The exaggerated force ductions, I showed you the video on in the other talk, so I'm not going to show it here. And a word about the spring back balance test. This is something Jampolsky originated. And it involves grabbing the eye. This is done in surgery. You rotate it back and forth, pull it way into, let's say, adduction, let it go, and see where the eye where it centers to. Then do the same thing and let it go from abduction and look for symmetry. And that's a way of testing for residual restriction. But
it's important to note that this is not the end point for your surgery, because this doesn't assess innervational factors. Let me give you a hypothetical. If you had a patient with an acute lateral rectus paralysis, and you'd never do this, but if you could take them to the OR on day 1 and do spring back balance, the eye would probably center perfectly normally. That doesn't mean the patient doesn't need surgery. It just means there's no mechanical restriction. So again, this isn't necessarily telling you the end point for surgery. It's not like, oh, the eye centers well. I've done everything I have to do. It just tells you about the restriction. And another thing, N Palsy has made a lot of contributions, something he calls the string sign. If you do forced ductions and you look for this indentation of the globe, looking like a string indenting the globe, I think that shows up. That determines the presence of a conjunctival restriction. So intraoperative, do forced ductions as you go, spring back balance testing as you go, and you may want to use temporary bow knots. Position a muscle, use a bow knot, do your spring back balance test, do your forced ductions, and then see if it's where you want it. And if not, you finalize the knot or you reposition the muscle. A word about slipped muscles and stretch scars. Irene Ludwig is the one who described the stretch scar. And I do think that they're different. I'm going to show you the differences that I think. You must completely excise this extraneous tissue, this capsule of the slip muscle or the stretch scar, and suture good muscle to the globe. And we'll talk a little about the role of absorbable sutures when you may want to use them. So slipped muscles is actually due to a suturing error, thought to be. It occurs sooner. The muscle will appear as a markedly underacting muscle much sooner than a stretch scar. At surgery, the tissue anterior to the muscle itself is thinner. It's almost translucent. It's usually unilateral because it's probably due to the suture when you imbricate the muscle just being in capsule and not getting a good grip in muscle. So unless the same thing happened in both eyes, it wouldn't necessarily be bilateral. And because it's due to a suturing error, it shouldn't recur if you suture properly. So if I have a slipped muscle, I don't use non-absorbable suture. I think you can be fine with your standard absorbable suture, which is my preference. Now, the stretch scar occurs later. It's actually due to a intrinsic healing problem the patient has, where scar tissue keeps building up between muscle and the sclera, and it occurs, or can be, over years. It's thicker tissue than you'll see with the empty capsule. And it often recurs because there's an intrinsic healing problem. Irene Ludwig feels very strongly that you have to use absorbable sutures in these cases because it's apt to recur. And I have defaulted to following that advice. So I can't say what would happen if you don't, because I do. So here's a picture of the difference. This is a muscle slipped in the capsule. Here's the muscle itself back here. And this is an almost translucent tissue. Here's a stretch scar, and it can be harder to detect the interface. This is the interface of the muscle. You can see a little ridge. And I find it helpful to slide a muscle hook along the muscle, and you'll feel a little bump when you get to the muscle itself. And you want to put sutures in good muscle tissue here or here and throw all this stuff away. I want to differentiate what I just showed you from another type of pseudotendon. And this is what occurs almost always after a normal successful recession. This muscle was recessed
to here. And connective tissue tends to grow anterior to that. Usually it actually goes to the old insertion. Here it's thinned out, but you can see it right there. And I have been fooled on more than one occasion where I thought at a re-op I was hooking the muscle, and I hooked this. And it looks just like a muscle. It's the same width as the muscle. It's just thinner than it should be. And when you see that, pass the hook further back and see if you can snag muscle itself. This tissue plays no role in the motility, and you can just excise that and throw it away. And this is different than the pseudotendon that occurs in the slip muscle with muscle slipped in the capsule that I showed you before. A few things you want to avoid: anterior segment ischemia. Sometimes you can use intraoperative Botox rather than adding a third muscle or a fourth muscle. There is the vessel sparing technique. It's technically difficult, but doable. And I find sometimes pullover sutures are helpful with inelastic muscles. And I find this something I use infrequently, but in the right case, it's very helpful. I have a stiff inelastic muscle. I want to put it on an adjustable suture, and it just doesn't go back. It won't take up the slack. So what you do at surgery, I put 2 firm traction sutures in the muscle insertion. So this is an inferior rectus I operated on. It wouldn't go back. I wanted it to take up slack. And I pull the eye up and pass these sutures through the lid, tie them on cotton bolsters. And here she is on day 1 when I'm about to do the adjustment, and I see that the eye is in a nice overcorrected position, which is what I want, because now I can pull the adjustable sutures forward rather than rely on them going back. I don't use this often. I will say it's definitely uncomfortable for the patient, but many patients can put up with it rather than have an unsuccessful operation and have to go back to the OR yet again. And we're nearing the end. I just want to say a word about these orbital cysts that can occur after muscle surgery. They're inclusion cysts, probably caused because the suture, as it was dragged through the sclera, had epithelial cells from the conjunctiva on it, leading to cyst formation. These can be very tricky, and what you're seeing here is the tip of the iceberg. This is how it looked when I excised it. It was huge. And there's and it's important to know this if you ever deal with these. Very characteristic appearance. I've seen this in I think close to a dozen patients. The cyst forms right where the muscle had been recessed to. It's adherent to the sclera. The muscle attaches to the back of the cyst. And you've got to know that to look for it, because if you just cut the cyst away, you've lost the muscle. And I've seen that happen to patients. And unfortunately or fortunately, a pseudotendon often grows from the undersurface of the muscle to this point here. So what happened, this doctor hooked this, thought this tissue here was the muscle, cut the cyst out, and ended up with a lost muscle. So it's something you want to be aware of. And this Linda Doggy sent me this photo to confirm what I just described artistically. Here's a cyst. Here's a CAT scan showing the muscle attaching to the cyst, not to the globe. The globe and cyst adhere up here. And this was the front part of that little pseudotendon that grew that way. So finally, a couple things when you're hooking a muscle. Re-op, if the hook doesn't slide under the muscle, you may need sharp dissection under the muscle to cut down on the muscle hook. We could probably talk for a full hour about techniques. So summary, you first want to decide if it's fresh or previously muscles you're operating. It's based on whether there's a limitation of rotation, if there's an undercorrection or overcorrection. We talked a little bit about timing and some technical aspects. Not one size fits all. And I want to thank you again, and we'll end the screen share And let's see.
Hamid, you want to go first?
Okay.
Hamid, unmute yourself.
There is one question. How do you manage anti-elevation syndrome?
Thank you. So anti-elevation syndrome, the very first case I did, I realized that you got to get rid of the inferior oblique. So I did a denervation extirpation. And I subsequently realized you don't need to do that. All I do is take the inferior oblique. First of all, finding it, the inferior oblique almost always just winds up fusing with the inferior rectus. And it's really hard, can be hard to find that interface between them. You have to look carefully for the fibers are running in slightly different directions. Probe with your hook underneath and you may find an interface that is softer, it can come up. But you have to dissect that away. And I just detach the inferior oblique, suture it, and I just push it back into a far recessed position. So I'll just move it back from the level with the insertion to 4 or 5 millimeters back. The hardest thing about anti-elevation is making the determination. So I've got a patient, they had bilateral inferior oblique anteriorized, and I look this way, I look to the left, and this eye overshoots to know, is this residual inferior oblique overaction here, or is it anti-elevation here? Well, certainly if there's bilateral, you know it's anti-elevation. And that can be a very hard determination to make. Sometimes if you have a cyclophotic torsion here, you could say maybe that's inferior oblique overaction, but you may get that after the anterior transposition anyway. It's a hard thing to put in words, but when you just look carefully at their versions, you can just tell that it's this eye isn't able to get up. It's straining to get up. You can see the bulge in the lower lid on attempted adduction. But I've had more than one patient that I really worried of, which eye should I be doing? What's not, I think isn't commonly known based on questions I'm asked, is even though it's a restriction of elevation in abduction, forced ductions are normal because it's what I call an innervational restriction. The restriction comes on attempted elevation, the inferior oblique is innervated, and that restricts elevation. But if it's not being innervated, it's not a mechanical restriction. Forced ductions are normal. So I just convert it to a full recession. Then, of course, what you may have to deal with down the road is the DVD may come back. And then you have to address that superior rectus surgery or inferior rectus surgery. Okay.
We have a couple of, we have a few more questions.
Yeah.
One question is, if the medial rectus has already been restricted, if the medial rectus has been resected in a previous surgery, a resection of the medial rectus has been done in a previous surgery, how can you find out how much more resection or plication you can do if there is a residual?
You know, this is a matter of the art of surgery. It's by feel. You just, I can teach this in the operating room, but I can't just tell someone. You've got to do enough surgery that you can get a feel for how tight a muscle can be before it's too restricted. So you'll let's say, see with the resection, you cut it away, it's gone. So you have to make an assessment somehow before you do the resection of pulling the muscle and just getting a sense of how tight it's going to be. You don't want to restrict the duction in the opposite field. I know my fellows, when they write me about patients, former fellows, that's not the answer they want. They want me to say 6 millimeters, or something like that, but it doesn't work that way.
And unmute, sir. Murali, sir, unmute yourself.
Yeah, sorry. Have you ever had a overcorrection after DVD surgery? Overcorrection after surgery for DVD.
You know, that there's it's an interesting question, because I'd first have to ask what you mean by overcorrection. An overcorrection might mean the eye is now hypo.
Yes.
But is it an overcorrection if I had a left DVD, I operated, and now the right eye's going up? That's a different type of overcorrection, but it's in a way an overcorrection. But if you're talking about an actual overcorrection, hypo, never anything that's been significant. I have had some, I cover test them, and it's, 2 prism diopters hypo or 4 prism diopters hypo. But to say that I really had a cosmetically noticeable problem other than just measurement, I have not. I'm sure it can occur, but I haven't.
There is a question about anti-elevation.
Yeah.
Why should the inferior oblique be more innervated in an abducted position? Because it restricts the elevation in abduction. So why should it be more innervated in abducted position? Because it is restricting elevation.
Why is it more in abduction?
Yeah.
Well, the slide that I showed, I thought depicted it. So here's my left eye. In abduction, the inferior oblique now is, if you think of the neurofibrobascular bundle as the origin of it, and the insertions where it inserts, it's kind of parallel to the inferior rectus. It's got an insertion now that's a little nasal to a little temporal to its insertion. And when it's in abduction, those fibers are directly parallel with the visual axis. So it makes good sense to me.
Hamid, do you have any questions?
There's one question. Have you ever done Y split of the superior rectus in DVD?
Do what to the superior rectus?
Y split. Y split.
Y split to the superior rectus. I haven't heard of that being done. I'm not sure why one would do it, but the answer is no, I haven't done that.
How does superior rectus Faden work compared to superior rectus recession in a DVD?
Faden for DVD?
Yes.
Yeah, there have been people that did a lot of that. It's technically very hard. I mean, you're very far back, and going that far back on the superior because of the orbital rim is harder than going that same distance on the lateral rectus, for example. And you can get into problems with the superior oblique. What do you do with the superior oblique? Do you push it back? Do you suture over it? So it's technically a hard operation, but doable. An experienced surgeon can do it. I know Fadens in general went through a phase of popularity. I took the approach with Faden that, and I certainly do it in certain circumstances. My approach is I do Fadens when I have to, not when I can. If there's anything else that works well, that's my preference. There are a couple of reasons for that. The Faden is not, a general principle that I have is that when I can choose a reversible procedure from a not irreversible procedure, if they'll both work, I'll always choose a reversible procedure. Faden is not always reversible. When you go back on a Faden, sometimes you find the sutures are where they were put, and everything anterior to it completely atrophied and fibrosed, and it's no different than if you had resected it away. That's one extreme. Sometimes it looks just as nice and clean, and there's a muscle there just like it did at the end of surgery. And others, there's everything in between. So I can't count on reversing it. So I have not done Faden for DVD because I think that there are other things that work, but I know that there are people that do it and find good results with it. And all the more power to them, that's fine.
One more question, sir. How do you treat Heyman-Belchowski's phenomenon?
The what phenomenon?
Heyman-Belchowski's phenomenon, the vertical, in poor vision, one-eyed patient, you get a vertical nystagmoid movement.
So the Hyman-Bilshowski phenomenon is in DVD, when you put a darkening wedge in front of the eye. Is that what we're talking about? And you see a change in the deviation. I'm not sure I fully understand the underlying mechanism behind it, but I mean, it has to do with the effect of light on the ocular motor system. But it's not something I test for clinically. I mean, it's more something that's observed, a research tool, and so on. It doesn't factor into how I manage patients.
We have a few more audience questions. In a patient who has come for surgery for exotropia, if you find that there is lateral concomitance in only one gaze, what would you do? A lateral concomitance in only one gaze.
A patient that has diplopia and it's concomitant.
No, patient has come for exotropia surgery and has lateral concomitance in only one gaze.
For intermittent exotropia, lateral concomitant.
Intermittent exotropia, lateral concomitance in only one gaze.
Well, I think if they have the de novo lateral concomitance, the only thing that I can think to do is to scale back the numbers. They are prone to overcorrection in primary. Now, in theory, if you buy that it's caused by an overacting medial rectus muscle, one might make a case for recessing the medial rectus muscles a small amount and then commensurately recessing the laterals a larger amount. I've never done that though. I do a smaller amount of surgery. And fortunately, that's not in my practice, it's not a very common occurrence.
You have answered this question before. What is the role of inferior rectus plication in managing dissociated vertical deviation?
The role of medial rectus plication.
Inferior rectus plication in managing DVD.
Superior rectus plication.
Inferior rectus plication. Inferior rectus.
Yeah, I mean, I think we talked about that. I personally have no experience with it as the primary operation, just because I've preferred doing other things. But there are people that like to go to the inferior rectus as their primary operation for DVD, and just a different choice. I can't say that I have found one works better than the other, because in general, I like to avoid tightening, I'll say strengthening or tightening operations, unless it's combined with weakening an antagonist, like a recess-resect procedure, because I think they tend to stretch out. But I don't have experience with that for DVD.
Hamid, any questions?
There's one question from the audience. How do you manage flap tear, traumatic inferior rectus flap tear?
So a flap tear, of course, you have to recognize it. I think, I don't know how to describe this. You basically have to identify it at surgery, find the flap, and so I'm looking at an inferior rectus, and let's say the flap is attached to the anterior orbital contents. Find that and just suture it back to the muscle. Basically, you just repair it. You suture it back where it came from.
How does torsion factor in the management of superior oblique palsy, especially in bilateral acquired superior oblique palsy?
I heard management of superior oblique palsy.
No, how does torsion factor in the management, torsional assessment, factor in the management of superior oblique palsy, especially acquired bilateral superior oblique palsy?
So first of all, diagnostically, if you have unilateral, will cause 7 to 8 degrees of subjective torsion. And I would say if you have 10 or more, you certainly should at least look very carefully for a bilateral masked superior oblique palsy. I think that torsion, if present, and it usually is present with an acquired superior oblique palsy,
subjective torsion is present, you need to plan an operation that takes that into account. For example, and what are the things we do? Weakening the inferior oblique will help that. Tucking the superior oblique will help that. Just recessing the contralateral inferior rectus muscle will not have a significant impact on that. That's why I said if you have the deviation greatest in the field of the superior oblique and you aren't comfortable or don't like doing superior oblique tucks, you can address that vertically with the contralateral inferior rectus recession, but that's not going to get rid of the torsion. And I would simultaneously transpose the inferior rectus in the other eye to address, in the affected eye, to address torsion. The first time I ever did a Harada Ito operation was described after I went in practice. So it was a new operation. And I was thinking, when would I ever need to do that? The first patient I needed to do it on was a patient who had a superior oblique palsy, where the referring doctor only recessed the contralateral inferior rectus. The patient had satisfactory vertical alignment, but had symptomatic torsion. Now, when I said, if you want to avoid doing a tuck, you could do the inferior rectus in both eyes, recessing it in one and transposing it in the other. You might say, well, why not do Harada Ito in the other eye? I chose that set of muscles for surgeons who aren't that comfortable operating on the superior oblique. If they were comfortable doing a Harada Ito, they could just as easily do a tuck. So, but that would work as well. It's just doing two muscles instead of one when a tuck would suffice.
So how do you manage a lateral incompetence in exotropia after a unilateral recess resect procedure? Like you had a patient with exotropia, you have done a lateral rectus recession and a medial rectus resection. Patient complains of diplopia on side gaze.
So if we're talking about the lateral incompetence syndrome where it drops in both right and left gaze, I don't think I've ever seen that after a recess resect procedure because the recess resect procedure creates incompetence. So I have certainly seen it where they'll be less exotropic in abduction in the operated eye, but I don't think I've ever seen it where it would be in both eyes. So what would I do if I did have that? Well, I would probably, it would depend a little bit on what the numbers were. I mean, this is all hypothetical because it's just not something I've ever seen. I'd probably do a recess resect procedure in the other eye and not doing a large recession, large numbers again, not wanting to increase the already small deviation in abduction of that eye. I just don't, I don't think, I'd have a hard time imagining that occurring though.
Madam, you have anything to say, Chitra, madam?
Yeah, I think we've had a very good discussion, so I shall go on to the concluding remarks. It's been an amazing webinar to remember for a long, long time because there's been so much of information transfer and so much of clarity which has come through. And thank you so much, Dr. Burton, for giving us so much time. And I'm sure all of those who attended the webinar would be truly grateful. Special thanks to Dr. Murli and Hamid for such a awesome moderating and the amount of energy and passion they have shown in ensuring that this meeting came to happen. A very special thanks to Sun Pharma for coming forward to sponsoring this webinar. Thank you so much. And thanks a lot finally to my dear attendees for being with us, for encouraging us to come back to you again with more useful webinars. Thank you one and all. Thank you, Dr. Burton.
Thank you.
Dr. Burton.
Have a good night.
Thank you. Thank you. Thanks, Murli. Thanks, Amit.
Thank you, ma'am.
Thank you, madam. Thank you, madam.